Although delirium affects up to 30% of all older patients admitted to hospital, it often goes unrecognized. Early recognition of delirium allows for timely treatment of underlying causes and implementation of other supportive interventions. High-quality bedside care can prevent delirium in up to 1/3 of older patients. People who develop delirium have high mortality, institutionalization, and complication rates, and have longer lengths of stay than non-delirious people. The DSM-5 definition of delirium states that it's a disturbance in attention and awareness, and a change in cognition that is not better accounted for by a pre-existing, established, or evolving dementia. The disturbance develops over a short period of usually hours to days and tends to fluctuate during the course of the day. It also states that there must be evidence from history, physical exam, or lab findings that the disturbance is caused by a direct physiological consequence of a general medical condition, intoxicating substance, medication use, or more than one cause. This component is unchanged from the DSM-4. Although it makes sense in theory, this component tends to be incompatible with clinical realities. Dr. Strang will explain this further.
So the DSM-4, bless its heart, says you should have evidence of an underlying physiologic cause. That's a stupid thing to say because half the time there is no evidence of an underlying physiologic cause. So is it not delirium anymore? They're acutely confused, half unconscious, and it's fluctuating, but we can't find out why. So that's not delirium? I don't think so. It is delirium. We haven't found the cause.
Additional features that may accompany delirium include psychomotor behavioral disturbances such as hypoactivity, hyperactivity, and impairment in sleep, and variable emotional disturbances including fear, depression, euphoria, or perplexity. The CAM, or Confusion Assessment Method, is the most commonly used tool to assess for delirium. When using the CAM, if a person is demonstrating both acute onset and fluctuating course, and inattention, and at least one of disorganized thinking or altered level of consciousness, they likely have a delirium. Let's take a look at these indicators in more detail. Feature 1, acute onset and fluctuating course, must be present for a conclusion of probable delirium. This represents a change in cognition from baseline and fluctuation throughout the day. Feature 2, inattention, must also be present in order for a probable delirium to be decided. This represents difficulty focusing. Along with acute onset and fluctuating course and inattention, one or both of disorganized thinking or altered level of consciousness must also be present in order to determine that an individual has a likely delirium. Feature 3, disorganized thinking, could be described as incoherent, rambling, illogical, or vague thought processes. Feature 4, altered level of consciousness, can be either hypo or hyper alert, lethargy, drowsiness, vigilance, or agitation.
So alertness, and then there's the whole thing about ANO, alert and oriented. So if you're writing that in the chart, I think you ought to have satisfied yourself that the person is actually alert. And what does that mean? Well, it means able to attend to a stimulus. So it means not drowsy or in a coma. It also means appropriately alert and not hypervigilant. So the hyperactive delirium, if you're trying to talk to them and people are walking by in the hall, every time someone walks by, they'll lose you. Like it's that, they won't keep sort of talking to you. You know, you're in the middle of a conversation and then they're off saying, what's that? Or changing the subject and that sort of thing. So that's an example of a hypervigilant delirious person or the overhead pages. Like, you know, it's irritating, but most people who aren't delirious, if you're talking to them and there's an overhead page, maybe they can't hear you now, but they don't stop paying attention to you.
A delirium can be hypoactive or hyperactive, or a mixed delirium fluctuating from one to the other. It's hypoactive delirium that most often goes unrecognized.
So which of the following people are delirious? A lethargic nursing home resident. Delirious? Yes. Yes. Lethargic. Now, you can be lethargic when you just woke up. And if you get over it in a few seconds when you more wake up, I guess that's not really delirium. So you would need some qualification that lethargic form, and you haven't just woken up. But other than that, you can correctly call it delirium. Hospital patient and the nurses said they were confused last night, but now the medical resident is seeing them and they're perfectly fine, and the mini-med is 30. Delirium? Yes, by definition, absolutely. So this was a talk designed for doctors, right? Just to say, look, read the nursing notes. That gives you the diagnosis. That's why they're there. I'm preaching to the converted here. So somebody who has dementia, and usually their behavior is okay, but now they're agitated, that person certainly should think of as probably having delirium. A post-op patient that's drowsy. Why not? What else could it be? Right. So if you're on morphine and the halothane hasn't quite worn off and you're drowsy with decreased level of consciousness, why is that not delirium induced by morphine and halothane? It is delirium. It's obvious what's caused it, and it's, not really unexpected in the situation, but it's still delirium. Like, you're on drugs, you're out of it. That's delirium. I'm sorry, it is. Now, just because your patient's delirious doesn't mean there's been any malpractice involved, right? You just did surgery. You had to give them all those drugs and put them unconscious. And same in palliative care. So when they say that 80% of palliative care patients go through a delirium before they die, that's what they mean. Like, sooner or later, there's alteration in level of consciousness, and it's all delirium.
In making a diagnosis of delirium, you must ensure that it is not a pre-existing dementia, particularly Lewy body dementia, as the likelihood of perceptual disturbances like hallucinations and delusions is greatest with this type of dementia. You must rule out psychiatric syndromes like depression, psychosis, and mania, and ensure that aphasia or other communication impairments are not being mistaken for cognitive deficit. Symptoms of delirium can look a lot like dementia, so some key differences are important to consider. The greatest diagnostic tool is collateral history from a familiar observer. The more recent the onset and the more profound the change, the more thorough a search for cause should be. Hypoactive delirium can look a lot like depression, although delirium is more acute, with more fluctuation, and is more labile versus the persistent depressed mood or anhedonia of depression. In some cases, a treatment trial may be necessary. Risk of delirium can be divided into two major categories: factors that increase baseline vulnerability or predisposing factors, and then the factors that can lead to the onset of an acute delirium or precipitating factors. The frail elderly are more susceptible to delirium, but more specifically, underlying brain disease such as dementia or Parkinson's, multiple morbidity, advanced age, poor nutrition, sensory impairment, and immobility are predisposing factors for delirium. Almost any medical illness, intoxication, or medication can cause delirium. Causes of delirium can be medical or environmental. Pretty much any deviation from normal routines or homeostasis can be enough to turn the tides for the very vulnerable. There are many mnemonics to help practitioners remember what things to investigate.
So there's more drugs with anticholinergic effects, but And then basically any drug that's sedating, so benzos, narcotics, even the Zeds, Zopiclone and all that. All anti-Parkinsonian drugs can cause delirium. All anticonvulsants, including gabapentin. And then, any street drug, of course, or alcohol. Some you wouldn't know about, NSAIDs. So it used to be relatively common with some of the old ones. Phenylbutazone, which is off the market, but also indomethacin, which is still on the market and people use for gout. But if you give a prone person a high enough dose of anything, Celebrex or Voltaren or any of those ones, you can cause a delirium. H2 blockers, so especially cimetidine, so it was particularly notorious for that. And especially when that was one of the few acid reducers we had, like, before PPIs and all that. So people were getting lots of it. It's apparently quite possibly deliriogenic. Nobody uses cimetidine anymore. Ranitidine, I think it's a lot lower risk, so it's really not much of an issue these days. Maxaran, people in Winnipeg are far too in love with that drug. It should be a hospital short-term drug only, as far as I'm concerned. Cognitive, and it causes Parkinsonism. So no, I don't think anyone should go home on that drug. And we should be trying to stop it when we find it. Central acting antihypertensives, those are usually the really, really, really old ones that almost no one's on, like Reserpine and Clonidine and Methyldopa. So there's hardly anyone on those anymore.
Delirium is dramatically underdiagnosed. It goes undiagnosed in 32 to 95% of cases. It's often dismissed as dementia or dismissed as just being old. One reason a delirium is often missed is because the diagnosis of the underlying illness may also be unrecognized. Illness in the frail elderly often does not present with the symptoms that you would expect to see. As a result, the fact that anything is wrong physically can be missed, and behavior brushed off as just being old or not coping. Acute illness in the frail elderly may present with altered or vague presentation. Some examples of symptoms that you might see are new onset incontinence, new onset falls, delirium or confusion, family members stating she just hasn't been herself, apathy, fatigue, and anorexia. Some examples of atypical presentation of illness in the elderly include pneumonia presenting without respiratory symptoms, infection without fever, the absence of chest pain in an MI, with shortness of breath being most common. Change in mental status is one of the most common presenting symptoms of acute illness in the frail elderly, and sometimes it's the only obvious one. Delirium may be the only presenting symptom of an acute illness, so you need to find out where the problem is and treat it if at all possible.
The assessment of delirium is to assess people for all those things, right? Get the collateral history, make sure it's delirium and not stable chronic dementia or depression. Examine them, are they coughing? Do they have a fever? Maybe some vital signs. Listen to their chest, check some oximetry, do a clinical assessment for acute illness. And then some basic investigations, and then there's no other set investigation. If you found something, you should check it up. And if you found nothing, then there's nothing to check. Not everyone needs a CAT scan, but if you find focal neurologic signs, or if they just fell and hit their head and have a big goose egg there and they're delirious, then you should do a CAT scan right now.
Despite common belief, urinary tract infection is unlikely to be the cause of delirium or functional decline in the absence of systemic toxic symptoms or signs. Pyuria and microhematuria are common and often of uncertain significance. Most older adults will test positive for asymptomatic bacteriuria. Investigate for other symptoms of UTI while investigating for other possible causes of the delirium. If clinical signs of UTI are found, then a culture should be ordered to confirm or refute the diagnosis and guide treatment. Many cases of delirium could be prevented with an awareness of the atypical presentation of illness in frail elderly and the provision of good bedside care. Attending to the needs around pain, nutrition, elimination, exercise, medications, sleep, hydration, emotional needs, stimulation, and medical status can go a long way toward maintaining optimal cognition and avoiding delirium. Delirium is not as reversible a phenomenon as it was previously considered. Many cases last greater than 30 days, and with an underlying dementia, as few as 20% return to baseline at even 6 months. The outcomes of delirium range from full recovery to long-term cognitive impairment and prolonged hospitalization or institutionalization, so prevention is really the key. As there's no specific treatment for delirium, trying to keep the environment as pleasant as possible and meeting as many of the client's needs as possible is the best approach.
Right, there's no specific general treatment for delirium. All you can do is treat the underlying condition and make it better. So you can prevent delirium. Once people get delirium, they've got it. You can maybe give them Haldol, but it's really too late. You have to treat the underlying condition and hope they recover. And it sometimes takes forever. And at home, if people are delirious, well, that might be an indication to go to hospital if they're just newly delirious and you guys are out there seeing them. If they've already been assessed and there's nothing to be done, then you use the antipsychotics basically for agitation or symptom. There's no other benefit. So if they're really agitated, we should give them some Haldol or maybe some risperidone. But if they're not agitated, then you don't give them anything. In fact, give them less. Give them as little as possible until they clear.
So awareness and prevention are really key when it comes to delirium. Congratulations, you've now completed the Rehab and Geriatrics module on delirium and the older adult.